Thank you. Delighted to be back in London again for the Invest in ME conference. My presentation will be dealing with the case definition and particularly implications for epidemiology, etiology, and pathophysiology. As you can see from this first slide, fatigue is very common within the general population. At any one time, about 25% of the population experiences general fatigue. However, 100% of people at some point experience this phenomenon of fatigue. So it's very common, and often that makes for one problem in communication because many people who experience general fatigue assume that they understand what things like ME are, and they really are very different types of fatigue. We often kind of think about it like with the Eskimos. There's probably multiple ways of looking at snow if you're familiar with snow. If you've experienced severe fatigue, there's also many different ways of experiencing that, not just the general way that the general population does. However, about 4 to 5% of the population experiences what we think of as chronic fatigue, defined as 6 or more months of fatigue. Clearly, this is a more severe type of fatigue than just something that occurs that's more a day or a month. Also, as evidence, there are many different kind of reasons as to why a person might have 6 or more months of fatigue if one looks at this particular diagram. A person could have cancer, medical problem causing fatigue. Certainly in our society, there are many people who are working several jobs and overstressed. That can certainly cause some of this 6 or more months of fatigue. Also, psychiatric issues, primary affective disorders like depression. One of their characteristics is also fatigue. So these are the different reasons, although it's somewhat simplistic, but certainly illustrative, that chronic fatigue is caused by multiple different factors. And of course, our interest is kind of in this particular arena. Case definitions of 1988, Holmes in 1994 are very important for a variety of reasons. First thing, the name that one is given to a case definition can have certain types of stigma-inducing properties. We'll talk about that. In addition, once a case definition is determined, it can be used in prevalence research, and it can end up being ending up finding underestimates, and that can also cause problems when the case definition changes over time. And I'll also illustrate problems with that issue. Finally, case definitions, if they lack sensitivity and specificity, and we'll talk more about what those terms mean, can potentially identify people with solely primary affective disorders. In a sense, really what I'm talking about is like a house of cards. On this bottom level, you have the foundation. This whole stack of cards is vulnerable unless that foundation is really solid. So the foundation is your case definition, and this is the way it works for all of science. Who has an illness, who doesn't have an illness, and then everything gets built on top of that. Your epidemiology, your search for biomarkers, your clinical trials, all these things rest on whether you have a case definition that has reliability and hopefully validity. So let's first talk about the name that's given to a case definition. Does it make a difference? As many of you are aware, the CDC named the illness CFS in 1988, and that was the so-called Holmes criteria. There was considerable patient dissatisfaction with that name because it trivialized the seriousness of the illness. In the mid-1950s to the mid-1980s, the illness had been, as you know, in Great Britain, known as myalgic encephalomyelitis, and that is the name that still is being used in a number of countries, including this particular one. Now, do attributions make a difference? Well, we tried to study this about a decade ago, where we gave medical trainees a similar case definition of a person with typical symptoms of ME/CFS. And in this presentation, I'm going to refer to this illness as ME/CFS. Trainees were given different names for the patient's illness, but it was the same basic patient protocol. Trainees were then given a questionnaire measuring attributions regarding the cause and nature of the illness. This is, again, a classic social psychological paradigm for trying to evaluate attributions. This is just one of the questions on our attribution list, likely improvement within the next 2 years. Again, as is evident, if you had the name CFS with this particular case, you would have almost twice, actually more than twice as high likely improvement. If you had the ME name, this is the likely improvement in terms of percent. So you can see with this slide, and of course we could give many other examples, names do affect attributions. And the term ME, which is a medically sounding name, basically does give attributions that this illness is more serious and has other types of more devastating implications than a name like chronic fatigue syndrome, which has been considered by many patient organizations as trivializing the condition. Certainly, this research supports that contention. In addition, as case definitions change from 1988 to 1994, you also see that this particular, you can see this percentage of people who are identified as having the illness actually almost doubles. So as you change a case definition, your prevalence rates or your definitions of who has or doesn't have an illness actually changes, in some cases rather dramatically. And this, again, has incredible implications for the identification of biomarkers. We think that the Fukuda criteria of 1994 actually expanded, broadened the case definition that had been there prior. So let's real quickly go over the 1994 case definition. I'm sure everybody here knows what it is, but just for those of you who aren't as familiar, patients need to experience 6 or more months of fatigue and at least 4 of 8 other core symptoms. So I'm going to list the symptoms up here so that we can all see them very clearly. And these 5 symptoms are things that you're mostly aware of. The 3 down here I'm emphasizing in red. And the reason I'm doing that is because post-exertional malaise lasting more than 24 hours is clearly the cardinal symptom of this syndrome. Impairment in short-term memory and concentration are often thought of as the thing that many patients say is the problem they have that stops them from going back to work because of this type of impairment. Unrefreshing sleep, again, classic. These are the cardinal symptoms. We're not saying that these things do not occur. We're just saying that these are the cardinal symptoms of the syndrome. But here's the problem with this particular case definition. A person could get 4 symptoms out of these 5 and actually end up having none of these 3 symptoms. So can you imagine that one particular laboratory or investigation team might have people who have very few of these symptoms? Another team might have people who only have these symptoms. When you compare these 2 samples, ultimately, some of the biomarkers that you're going to identify might be very different because of the nature of the patients that you select. What we're really referring to here in scientific terms is polythetic criteria, criteria in which not all the symptoms need to be present to make a diagnosis. Use of polythetic criteria derived by expert committees, as in the case of CFS and Fukuda, they might not be methodologically sound. Now, let me give some potential reasons for problems with this. Let's take the difficulty with a misdiagnosis of major depressive disorder. Now, it's possible that a person with ME/CFS could be diagnosed with a major depressive disorder. Depression of a major depressive disorder often involves chronic fatigue, and we're going to go over this point again and again during this lecture. But they also could have, a person with major depressive disorder, these 4 symptoms. These 4 symptoms, as we just mentioned, are Fukuda symptoms as well. So a person with classic major depressive disorder could meet criterion for ME/CFS. If you bring people in with major depressive disorder into your study and compare them with people with ME/CFS, you can see the complications that would occur when you're trying to identify potential biomarkers. patients with a primary affective disorder could be diagnosed, but these are distinct illnesses. Several ME/CFS symptoms are not commonly found in depression. So, for example, prolonged fatigue after physical exertion, night sweats, sore throats, swollen lymph nodes. Illness onset with ME/CFS often occurs over a few hours or days, whereas primary depression generally shows a more gradual onset. So, including the latter type of patients with major depressive disorder in this ME/CFS case definition, particularly as denoted by Fukuda, could complicate our efforts to identify biological markers. Again, to emphasize, this is 6 or more months of fatigue. That's that initial diagram that we had put up there. We think ME/CFS is one subgrouping within this larger group of people with 6 or more months of fatigue. As we mentioned before, some have cancer, heart disease, or other types of illnesses, certainly, that could be causing chronic fatigue. But depression also could be causing 6 or more months of fatigue. The key question is, people in this particular category, are we bringing some of these people in to our diagnostic work? And if we are, is that going to make it more complicated to find out the biomarkers within this particular category of ME/CFS? Now, our group in Chicago actually took this challenge. Could we differentiate ME/CFS and major depressive disorders? So we actually identified 2 homogeneous groups that had no overlap, and we were able, with these particular tests, and I'll briefly mention them, to do 100% differentiation of the patients in these 2 groups. So if you really have these type variables, for example, self-reproach. Self-reproach, you generally, this is with the Beck inventory, you generally don't get this in ME/CFS patients. You do get it within the major depressive disorder. Shortness of breath, very interesting. You don't even have that symptom on the Fukuda criteria, and yet it's a differentiator. And then the reason I kind of mention these up here is that these are not just frequency of these events, they're severity of the events. The frequencies were not discriminators. It's the severity that discriminates these particular conditions, major depressive disorder and ME/CFS. And I'll, again, talk about that a little bit later as well. So it's getting it right, which is the critical thing, and getting the right measures. If you get the right measures, you can make 100% differentiation. If you don't get the right measures and you basically bring these groups together, you potentially have some diagnostic confusion. So again, to emphasize, case definition determine who have and do not have an illness. It's the pyramid. It's that basic foundation. Now, for epidemiology, it influences our estimates of how many people have an illness. In particular, if few people have an illness, potentially less resources could be devoted to it. On the other hand, if you get it wrong and you basically bring too many people in as a particular diagnostic event, and too many people you indicate have an illness, you also have problems because you might be bringing people in who don't have the illness and then complicating the efforts to basically identify biomarkers. So let me real briefly kind of show a 10-year odyssey that has occurred in the United States regarding the prevalence estimates. In 1997, based on the 4-city study that some of you are familiar with, they estimated ME/CFS to occur in 4 to 8.7 persons per 100,000. By 2003, using a community-based efforts, the estimates had gone up to 240. And then in 2007, with reports of the Wichita study and the Georgia study, we see these rates going up to 2,540 per 100,000. So the Georgia study, in contrast to the Wichita study, in contrast to the 4-city study, this is almost unprecedented to have these types of changes in prevalence occur for an illness. The difficulties in us finding biomarkers are magnified if our estimates of who has this illness is changing. There are really 2 reasons for these dramatic changes in prevalence, and I'm going to try to go through those 2 reasons. But you can see, in a 10-year period of time, the rates went from this particular domain affecting probably about 20,000 people to this particular domain in the U.S. affecting over 4 million people. That's really a remarkable change in epidemiology prevalence. And again, in part due to methodology of epidemiology and also in part due to the case definition changes. So let's go through the first reason that this changed real briefly. The first studies done in the 1990s involved physician referrals. Physicians had to identify patients from their practices, and the CDC basically, this particular case definition, if a physician didn't believe that ME/CFS existed, they wouldn't recruit people into the study, and if people basically didn't have a physician because they're out of the healthcare system, they wouldn't be brought into the study. So with those two methodological flaws, they estimated that this was about 20,000 people affecting primarily white middle-class women. The reason this was a problem is that if the illness is perceived as relatively rare, you'll have less public and federal resources devoted to it. Our group in Chicago, 1995 to 97, did a random community-based study, and we tried to correct for some of the methodological flaws of this CDC effort. Doing this type of research really ended up allowing us to go from an estimate that was, again, in that little area there to this area here. So you can see dramatic change, and this was also primarily based on methodological estimates. So from 20,000 to an estimate of 800,000, and interesting, 90% had never been diagnosed. So let me real briefly kind of indicate how one does community-based epidemiology. One first tries to identify an area, whether it's urban or rural. One then tries to find a random sample, and you can get that by working with survey research methodologists and companies, and you basically can purchase those particular numbers. So you can either telephone call people or you can go out into the community and knock on doors, but you want to get a random sample. You identify people who have some of the cardinal symptoms, as I suggested, and then those people are brought into a hospital for a complete medical and psychiatric workup. Then you have an expert committee that basically takes all the data and makes judgments as to whether you think they meet the criterion. It's critically important in doing that type of work to be very sensitive to identifying people, particularly if you're dealing with folks who, for example, speak Spanish in the United States. So you want to have Spanish-speaking people make some of the telephone calls so they can speak to someone in Spanish. You also want to be able to increase the probability that a person will be brought to the hospital. So you provide child care arrangements, possibly some incentives so they can have someone to look after their kids. You help them with transportation back and forth. And you have someone, for example, if they're Spanish-speaking, actually talk to them and work with them. So the cultural sensitivity of your research is critically important to make this type of epidemiology community-based studies work. Now, the second issue, besides the methodological one for epidemiology in terms of using community-based studies, has to do with criterion variance, and this deals with the case definition. Researchers know that diagnostic unreliability leads to disagreements among scientists regarding diagnostic decisions. And this is really the case of the last 60 years for the DSM, Diagnostic Statistical Manual. Criterion variance accounts for the largest source of diagnostic unreliability. What that means is differences in the formal inclusion and exclusion criteria to classify patients' data into diagnostic categories. Criterion variance occurs when operationally explicit criteria do not exist. Let me give some examples. So what does it mean to operationally explicit objective criteria? This is a requirement for reliability. This is, again, the classic Fukuda symptoms, and this is a 100-point scale with intensity. This is very low intense. This is very high intense. This is today. This is during the worst period. And as you can see here, this is a person who has 4 symptoms, but they're very low. Well, this is actually a healthy, normal person, just to show that the occurrence of something isn't really critical. The occurrence doesn't make the difference between a person having healthy versus an ME/CFS, but it's the severity. This is the intensity of a person with ME/CFS. And you can see during the worst period, there's dramatic problems in all these areas. It's not the occurrence, it's the severity that really makes a differentiation. So you got to get it right. You got to ask the question the same way, different researchers, different labs, to identify this phenomena. We'll talk about it again with this MDD, major depressive disorder. If you ask the question, for example, does fatigue last for 6 months or more, you get about almost, there's no significant difference between the ME/CFS group, 100%, and this particular group, major depressive disorder, over 90%. Of course, they are different than healthy control group. So just fatigue doesn't differentiate these two conditions. You've got to ask the question, severity of the fatigue. If you ask the severity of the fatigue, this is a severity of, on a 100-point scale, this is an 80. It means very severe. This is under 50. So you can see this differentiates the two groups as well as the control. It's how you ask the questions to get it right to make the differentiations. There are additional issues that need to be considered. One needs to ensure that necessary information is elicited from structured interviews. So in other words, criterion variance defines not just being explicit about what you think you want to measure, but you also have to have standardized procedures, questionnaires, where everybody asks the questions the same way, so that you basically reduce this criterion variance problem. So, as an example, responses can vary depending on how a question is asked. If you ask this question, do you have prolonged, greater than 24-hour generalized fatigue or malaise? By the way, some people don't know what malaise means. After previously tolerable levels of activity, in this problem, this is a problem since you got chronically fatigued, only about 59% of patients with ME/CFS will answer that yes. But if you ask that question differently, you can get those rates up to over 95 to 100%. So how you ask the questions is critically important to basically identify patients with this illness. Now, I'd like to switch real briefly to new empiric CDC case definition of Reeves and others from the CDC who basically tried to deal with this criterion variance problem by trying to identify individuals meeting 3 issues of symptoms, fatigue, and disability. And they tried to operationalize these particular criteria. Again, there's nothing wrong with that particular effort. The question is how one does it. That's the critical issue, and that's where the details become important as to whether one gets it right in operationalizing the Fukuda criteria. So for the moment, let's just kind of look at the disability criteria and see a potential problem with how that was operationalized. The Medical Outcomes Survey, short form 36, often called the SF-36, is used to assess substantial reductions in occupational, educational, social, and recreational activities. One can reach disability by scores lower than the 25th percentile. And again, let me emphasize, 1 or more of the following scales. So of these 4 scales, you only need to reach that criterion on 1 of these 4 areas. Now, this is the one that I want to focus on, role emotional. Role emotional was never focused on in any way within the Fukuda criteria, and yet it's added here. What that means is problems with work or daily activities as a result of emotional problems, okay? Again, just emphasize, problems with work or daily activities as a result of emotional problems. If you reached the bottom 25 percentile on that, you would then meet the disability criterion for the empiric CDC criteria of 2005. The problem is that based on the mean of role emotional for a clinical depressed group, every clinically depressed patient would meet disability criteria for CFS according to this criteria. Every patient with major depressive disorder would meet your disability criteria. Why is this important? Using the empiric CFS case definition, Reeves and others in 2007, based on the Georgia study, estimated that 2.54% have CFS. That's over 4 million Americans. Very interesting, mood disorders are one of the most prevalent psychiatric disorders. 1-month prevalence rate of major depressive disorder is 2.2%. That's very interesting, 2.2%, 2.54%. Very interesting. Major depressive disorder, as we've emphasized, can be confused with ME/CFS as it has overlapping symptoms with ME/CFS. But as we've indicated, you can make differentiations between these conditions if you select the right instruments. It's possible that some patients with major depressive disorder also have chronic fatigue and 4 Fukuda symptoms that can occur with depression. But these are different disorders, as we've said again and again today. Our group tried to look at this issue a little bit more detail, and we identified two groups of people, one with CFS and one with major depression. All were given measures to assess symptoms based on the criteria of the 2005 empiric case definition. What we found, which was very interesting, was that in this major depressive group, MDD, 38% actually met criteria for ME/CFS based on the Fukuda criteria. 38% of people with an affective disorder met the criteria for ME/CFS. Let's give an example of one of the people who we classified as a major depressive case and how this person met the criteria. A female who had major depressive disorder, she had a clinical diagnosis of major depressive disorder. She demonstrated impairment on social and emotional functioning. Remember, social and emotional functioning, 2 important traits of depression. And for the medical outcome survey 36, she met the cutoff points for role emotional. As we said, every person with depression would. But let's look at this person's physical functioning score. She scored 100. In other words, that's the highest possible score on this measure. What this indicated, that this person had no difficulties with physical functioning. And that would be an indicator that this person did not have ME/CFS. So again, if you basically put this person with major depressive disorder into a group that basically you're studying for biomarkers, what are you going to find? You're going to be looking at a different disorder. So what we're suggesting is screening tests need to have high sensitivity and specificity. Sensitivity is the probability that a test correctly classifies a person with ME/CFS as positive. Specificity involves the test correctly classifying a person without ME/CFS as negative, that they don't have it. What we suggest is that the Reeves empiric case definition has problems. Now, according to Bayes' theorem, extreme care needs to occur with low prevalence illnesses like ME/CFS. Let me give you an example of what that means. If you have a sample of 100,000 people and you have a prevalence rate of 0.42, that would be probably about 420 cases, probably would be in that 100,000. And that 0.42 is the prevalence rate that we came up with in Chicago. Now, if a test had 95% rate of sensitivity and specificity, you'd identify most of the people with ME/CFS, 399 of the 420. So you'd get most of those people as being correctly identified. Here's the problem. With a low prevalence illness, you would identify 49,790 individuals who do not have ME/CFS, but were identified as having it. Okay? That's the specificity issue, because it's 95% of this 100,000. So 5% error rate is basically that particular number. That's the problem. So it's critical to identify with precision true negatives. We went back to the data that we had, and we used the same cutoff points that Reeves did, and we used what's called an ROC, receiver operating characteristic, and this particular diagram, again, indicates specificity of 0.5. That's a real particular problem. It has to be 0.9 or better, as we suggested. That means you don't have discrimination for basically identifying people who don't have the illness. Now, that particular study, we found it kind of interesting. It got published in September, and 1 week later, there was a rebuttal by the CDC for our article, which we thought was amazing. How did that happen within a week? We wrote a rebuttal to that rebuttal, and it took us 6 months for them to publish it. So that just kind of shows the importance of DePaul University. In any event, what took so long, right? But one of the comments that the critique made was that they said that there were flaws that precluded critically evaluating both their finding and conclusions. I must say I've written quite a few articles over the year. I'm not sure I've ever had any of my articles with a rebuttal like this. So, we kind of said, well, let's kind of think through this stuff. And we took another sample recently, and we basically had much better formal medical and psychiatric examinations. We ended up with 108 people who had medical and psychiatric workups from our community-based sample with the same instruments that the Reeves group had used. And we basically replicated our findings. This article came out a couple weeks ago, and the sensitivity and specificity outcomes for the Reeves criteria indicated to us that the recommended scales and cutoff points would not be considered a good diagnostic tool for selecting CFS patients from the general population. And that article is available for folks who want all the details. Let's talk about some of the implications of this. If you looked at childhood trauma and ME/CFS, Christine Heim used in 2006 the new empiric CDC case definition with the Wichita data to explore the influence of early adverse experience on risk. Childhood trauma is an important risk factor for CFS, according to this article, with almost 63% having some type of early abuse. When you get numbers that high, it's some people that will conclude that this might be really a psychogenic illness. However, our group, a couple years earlier, had used a traditional system of diagnosing ME/CFS, and what we found was the prevalence rates of sexual and physical abuse history among individuals was comparable with those found in individuals with other chronic conditions involving chronic fatigue, including medically based conditions. Relative to those with ME/CFS who report such early history, most individuals with ME/CFS did not report interpersonal abuse. So again, two different definitions, two very different outcomes, very important public policy implications of both studies. Our group in Chicago in 2007 used factor analysis to actually see if we could have a more statistical method for identifying the symptoms that people have with this illness. What's very interesting is that factor 1 and factor 4, factor 5 and 6 are pretty traditional symptoms that have come up in the Fukuda criteria, but factor 2 and 3, really we're talking about different things: vascular items, dizzy after standing, inflammation items, chemical sensitivities. This, again, got us thinking that rather than a group of people coming together and coming up with a case definition, if we use statistical methods to identify critical factors, it might be empirically based as opposed to consensus-based. What's very interesting about those factors that I just mentioned is that many of those factors are actually within the Canadian ME/CFS criteria. And a critical difference between the ME/CFS criteria of Canada is that they require these symptoms. Post-exertional malaise needs to occur, not an option as in the Fukuda criteria. It's required. Unrefreshing sleep, 2 or more neurocognitive manifestations, and at least one symptom from 2 of the following categories: autonomic manifestations, interesting lightheadedness as an example, neuroendocrine manifestations like recurrent feelings of feverishness, and immune manifestations like recurrent sore throats. So this is a group, we actually have a couple of the authors in the audience, in 2003 that were involved in developing these criteria. Now, in 1994, the 1994 criteria of Fukuda were actually compared with these 2003 Canadian criteria in an article that we published in 2004. And we actually were pretty impressed with these more sensitive and specific definition, in that we found in the Canadian criteria less psychiatric comorbidity, more physical functioning impairment, more fatigue weakness, and more neuropsychiatric and neurological symptoms. We published this article 5 or 6 years ago, and we thought that there would be more people, particularly in the scientific community, that would begin using these Canadian criteria, or at least using it in combination with the Fukuda criteria. We were surprised that it's not been used. It's only been used in a handful of studies internationally by the research community, and we think one of the reasons for this is because there's some difficulties in translating from the particular case definition into actually practice of how to operationalize with the questionnaire with more specificity to deal with the criterion variance issues that we talked about. So in 2005, we began working with an international group, and we decided to focus on the pediatric case definition. And we basically developed an instrument. We collected data internationally. We used the Canadian criteria as our model to look at pediatric issues. The pediatric case definition involved unexplained, persistent, or relapsing chronic fatigue over the past 3 months. It's not the result of ongoing exertion, not substantially alleviated by rest, and participants had to experience substantial reductions in previous levels of educational, social, and personal activities. So again, we were trying to operationalize what was within the Canadian criteria. Participants needed to evidence specific symptoms within the 5 classic ME/CFS symptoms. So you had to have the 5 areas that we talked about before, which needed to have persisted or recurred during the past 3 months. Of the people that referred to us by specialist clinics, 16 met full criteria, so we called them the research criteria. We also developed the clinical criteria. In this, they needed to meet 4 out of 5 classic symptoms, and also for autonomic, neuroendocrine, and immune manifestations, at least 1 symptom in any of the 3 categories. And 14 participants were diagnosed as clinical. So in a sense, we have the more tight criteria research, a little bit less tight clinical, but all of them could meet criteria. We then looked at the Fukuda criteria with the same youngsters. Of the 33 ME/CFS cases referred by physicians, 25 were identified as having ME/CFS with the Fukuda criteria. The ME/CFS criteria identified 32 out of the 33 as having ME/CFS. So what this means is that the pediatric ME/CFS criteria were more accurate in correctly distinguishing between the presence and absence of pediatric ME/CFS. This summarizes that study. The Fukuda criteria evidenced 76% sensitivity, 100% specificity. What that means is they would miss 24% of patients with ME/CFS. Our pediatric Canadian criteria of ME/CFS evidenced 97% sensitivity and 100% specificity. In other words, it would only miss 3% of patients with ME/CFS. In a population with a low illness prevalence, the risk of underdiagnosis is a key concern. And what this study suggested was that a diagnostic tool needs to have high sensitivity and negative predictive value, which this particular study suggested the Canadian criteria for pediatrics did. For the last year, our group has been thinking about how we can take a look at the Canadian criteria and also do something similar to what we did with the pediatric criteria, which is try to operationalize these criteria so that they can be used better by researchers internationally. So real quickly, to go over some of the issues with this Canadian adult definition, the illness needs to persist for at least 6 months. You survey items specify that those symptoms should be assessed over 6 months, and you need to have severity and frequency scores. So the original Canadian criteria is one example of one of the problems, had a scale measuring severity. So a symptom can be severe, but it could rarely occur, okay? So you really need to get the frequency as well, not just severity. So in our scale that we now have that goes along with the symptoms, a person has to experience a symptom over the past 6 months, and you can see that this is, you'd have to have 0 or 1. We really wouldn't count that, but a score would have to have 2 or higher. So this is the specificity. You've got to say this is the cutoff point, and a person that meets 2 or higher would meet this particular symptom. But severity index also has to be defined, and we now specify that symptoms are present or rated on the following scale, again, needing a 2 or higher. It needs to be at least moderate. So frequency and severity have to be something that you can measure, and you can say it has to be at least these elements to meet criterion. Let's just kind of look at another issue, lifelong. What does it mean to have lifelong fatigue? The adult definition of Canadian criteria required that fatigue not be lifelong. Well, 2 people are going to look at that statement and are going to say something different about whether it means lifelong. Does lifelong mean 5 years, at 10 years? You really need to have a question that operationalizes it. So this is our question. If a person said yes to this question, they would not meet the criteria. Have you always had persistent or recurring fatigue energy problems, even back to your earliest memories as a child? By persistent or recurring, we mean that the fatigue energy problems are usually ongoing and constant, but sometimes there are good periods and bad periods. The issue of stamina endurance is also critical. Some patients are not chronically fatigued, have lengthy times to recover following minimal degrees of activity. So a person who participates in very little activity possibly to minimize ME/CFS symptoms when compared to his or her same-age peers, and becomes exhausted after minimal exertion should not be excluded from an ME/CFS diagnosis. So questions are asked about to identify individuals who have low stamina and endurance but currently have less fatigue because they are severely limiting their daily activities. Post-exertional malaise, again, a critical phenomena. We have actually developed a questionnaire called the ME/CFS Fatigues Type Questionnaire, which we've published a couple of data sets on. And we have found that there is a factor called post-exertional involving items like physically drained or sick after mild activity, minimum exercise makes you physically tired, and we have now used some of the items from this questionnaire. And this is, again, as you can see, what's really fascinating about this particular study is that fatigue items can really be broken down into these 5 areas, and you actually get very different factor scores for a group of people with ME/CFS. If you ask these same items to a person who's healthy, you'll get 1 factor. They don't discriminate between these different issues. If I basically said wired but fatigued, everyone here would say, oh yeah, I get it. People in the healthy, normal population have no idea what you're talking about. How to measure substantial reductions. Our group has looked at role emotional, and it actually had the lowest threshold for identifying individuals with ME/CFS and identifying others who do not have the illness. We actually have just finished a literature review of all the SF36 studies looking at ME/CFS versus control groups. Role emotional and mental health functioning were clearly the worst factors in terms of making any types of meaningful separations. However, these 3 factors, vitality, social functioning, and role physical, both in our literature review and in several studies that we have now done, capture significant limitations in a person's ability to have energy and accomplish activities. So again, the key thing that we're talking about is we're not just coming up with these particular measures based on what we think makes physical functioning difference, but we're actually doing empirical work to support it. So being specific about the criteria, you have to basically specify scores, and you have to basically indicate what it is meeting criteria for substantial reductions or not. And this is our scoring sheet that we have. You can't actually see it, but each of these but each of these dimensions that are referred to have specific rules. And if you meet the criteria or don't meet my criteria, they're specified. And that's what needs to occur with the case definition. You have to not just have the variables defined, a questionnaire to use, but actually something that can be used for people to score it so that it can actually know whether a person meets criterion or not. By the way, we have finished modifying this questionnaire, and for those of you out there who would like copies of it, just feel free to email me. We're happy to share it with you, as well as a manuscript that describes our theoretical reasons for developing this. Our next tasks are... Sure. We're trying to specify criteria and develop a questionnaire to collect data on ME/CFS. And we're beginning also some work on a pure ME case definition, reviewing the work of Ramsey and others who have worked in this area. And in this new system, we're actually developing level 2 and level 1, self-report manifestations and biological documentation. So in conclusion, since I'm down to my last minute, the scientific enterprise depends on reliable and valid ways of classifying patients into diagnostic categories. This is a critical research activity that can enable investigators to better understand etiology and pathophysiology. When diagnostic categories lack reliability and accuracy, the quality of treatment and clinical research can be compromised. If ME/CFS is to be diagnosed reliably across healthcare professionals, it's imperative to provide specific thresholds and scoring rules for symptomatic criteria. ME/CFS has gone from being considered a relatively rare illness in the early 1990s to one affecting about 1 million in the early 2000s. Now the CDC suggests as many as 4 million people in the U.S. have this illness with the broadened criteria. Our contention is that this might include some with primary psychiatric illnesses such as major depressive disorder. Using a broad or narrow definition of ME/CFS will have important influences on ME/CFS epidemiologic findings, as I've suggested, on rates of psychiatric comorbidity, on how patients are treated, and ultimately on the likelihood of finding biological markers for this illness. Thank you.